Hi everyone. In this lecture we're going to cover thermal modalities, and these will be the first group of modalities that we will start to work on in the lab. So it is very important that you view this lecture prior to going into the lab to practice. I do want to make clear too that when I say thermal modalities, we're talking about anything that is heat or cold. A lot of times I say thermal and I think people automatically assume heat and sometimes forget that cold is included in this as well. So we're going to go through, we're going to sort of compare and contrast thermal modalities, both heat and cold, and then we'll talk about some of the common modalities that you'll see in the clinic. So with thermal agents or thermal modalities, we're going to transfer the energy either to or from the tissues, and that's going to depend on the type of modality that we're using. It's based on a temperature gradient, which basically just means the greater the difference in the temperature between the person and the modality that we're applying, typically the faster the exchange of energy is going to happen. Heat is going to involve some sort of exchange of kinetic energy, which can be conduction, convection, radiation, evaporation, or conversion. And as we go through the different types of modalities, we'll talk about what type of energy is exchanged with those. Tissue types are going to conduct heat differently. So skin is going to conduct heat relatively easily. Muscle will absorb heat relatively easily. Adipose or fat is going to kind of serve as an insulator when it comes to heat in most of the thermal modalities that we talk about in this particular chapter. The thing to remember too is that energy is going to be absorbed by the more superficial layers first, which means less and less is going to be transferred to the tissues as we get deeper and deeper. If we think about what we're typically trying to target with heat and ice or thermal modalities, it's usually down to at least the muscular layer. So we've got to get through the skin, we've got to get through the adipose in order to get there. So patients with different tissue types, varying degrees of adipose, there's going to be differences in how much heat the target tissues are going to be able to absorb. So as I mentioned, kinetic energy is going to be exchanged for ice packs, cold packs, and hot packs, which are probably some of the most common modalities you're going to see used in the clinic. Those use conduction. Whirlpools, which may still be around a little bit, we will talk about them. They use convection. Infrared lamps, which we don't really see too much anymore at all, really. We use different types of light therapy, which we'll talk about at the end of the chapter, can use a form of radiation. Diathermy and ultrasound, which we will talk about, those use conversion. They're basically taking one type of energy and converting it to another. And then vapor coolant spray is one that we will talk about this time around. It uses evaporation. So cold application. Typically when we think of cold, we're thinking about applying it during the acute inflammatory stage. Initial injuries, most people know this. One of the first things they're going to do is grab an ice pack or put some ice on it. And so again, clinically, that's one of the things that we can definitely do with our patients. There are some theories about using ice before range of motion activities. It's called cryokinetics, using things like whirlpool or immersion. It's not something that I'm a big fan of, and we'll talk about why. That might not always be the best idea. But again, clinically, a huge thing we use it for is going to be after physical activity. So the person comes in, they go through their treatment program, they're sore at the end, give them an ice pack or some form of ice to try to calm things down before they leave for the day. Cold modalities are used to regulate the inflammatory response, which we have talked about. They're going to try to limit the scope of the original injury, right? So someone gets that initial injury, that primary injury, and then there's all those chemical irritants released in the area that can start to further irritate and sort of extend the scope of that initial injury. And ice is going to help to limit that or reel that back in a little bit. Ice can help to decrease pain and decrease muscle spasm. This is something that not everyone is aware of. Muscle spasms do respond pretty well to ice. So if I can convince someone to use ice on a muscle spasm, I will usually try to do that. Heat is indicated as well, and we'll talk about that when we get to the heat section. But I have found that ice tends to work a little bit better. Ice can be safely applied to most injuries, which is nice. You often cannot go wrong with ice. And with ice, heat is actually absorbed from the skin to the cold modality. So the physiologic effects of cold application, we're going to have vasoconstriction. So again, remember in that acute inflammatory phase. Everything's just kind of leaking out into the area. So if we can put some ice on it, cause the blood vessels to constrict a little bit, less is going to be able to leak out, which goes along with, go a couple down here, to decreased capillary permeability. Again, limiting the scope of that initial or primary injury. It's going to decrease cellular metabolism, which again, acute inflammatory response, histamine being released, all that is going to increase local cellular metabolism. It's going to decrease the production of cellular wastes, so less to be dumped out in the area. It'll reduce inflammation. It'll decrease nerve conduction velocity, so that pain signal to the brain will actually slow down a little bit. It can decrease pain and muscle spasm, as we just mentioned, and it will also decrease muscular force production, which is again why I'm not a huge fan of the cryokinetic thing. So using ice before activity. I certainly prefer to use ice after activity. So with tissue cooling, again, the greater the tissue temperature gradient, which is again the difference between the temperature of the part that you're putting it on and the modality itself, the more rapid the energy exchange is going to happen, and also the deeper the effects are going to get. Also, the longer the treatment, the greater the depth of cooling. So the longer you leave the cold on, the deeper it's going to be able to get. Adipose is going to be a limiting factor. So again, if your patient has a significant amount of adipose, we do have to start to consider, is the ice going to actually get where we need it to? Decreased sensation or decreased circulation may put the patient at risk for injury. It is possible to burn someone with an ice pack or actually induce frostbite. And so we do need to ensure that the person has adequate sensation so that they can actually feel it getting cold, let you know if it's getting too cold, and be trustworthy with that information. We also need to make sure that they have intact circulation to the area that we're putting the modality on, because what's going to happen is warm blood is going to be circulated into the area, which will help to counterbalance some of that cold and keep it from getting too cold. So if they have impaired circulation, they're not getting that warm blood flow to the area, they may actually get too cold, which again could potentially cause an injury. Cold packs and ice massage. So ice massage is going to be ice applied directly to the skin, usually for short periods of time. And then cold packs, or the typical cold packs that we use in the clinic, those are going to actually produce the greatest temperature gradient, which means they have the greatest potential to decrease the tissue temperature. Whirlpools are going to affect a larger treatment area. We can typically put more of a person into a whirlpool than we can cover with a cold pack or with an ice massage. And so that can, again, have some effects because we're exposing more of the person's tissue. They do have about the same effect on intramuscular temperature. Keep in mind that compression wraps will more significantly reduce the skin temperature. So if you put ice on an area and then you wrap an ACE wrap around it or wrap a Velcro strap around it, sometimes we do that just to hold the ice pack in place. Do keep in mind that that will make it cool even faster. I'll tell this story because I usually do. Many years ago, my husband was running, was having some calf pain when he was finished repeatedly, so he would typically ice when he got back from a run. This particular day, he put an ice pack on his calf, he used an ACE wrap to hold it into place, and he sat down on the couch and propped his legs up on the coffee table. Between the compression wrap, the compression of sitting with the leg on top of the ice pack and leaving it on for a long period of time, he did actually burn himself with an ice pack. He had a huge area of discoloration on his calf, and it took a really, really long time for it to go away. So be careful with the ice packs. Maximum analgesia, which is pain relief, is going to occur when the skin gets to about 58 degrees and sensation is going to return at 60 degrees. I don't expect you to memorize those numbers. What I do want you to know is that, one, it takes about 20 minutes for that to happen. And if you think about how long you've actually usually applied ice or seen it applied in the clinic, typically about 10 minutes is what we leave ice on. So it usually takes a little bit longer than that to get maximum pain relief from an ice pack. The other thing I want you to take away from that is a very fine line between pain relief and loss of sensation. Also, the increased risk of cold injury is about 55 degrees. So it's a very small window of where we're getting pain relief, loss of sensation, and then potential injury as well. So again, just use caution when you're using ice packs. So some sensations associated with cold, obviously cold, but it can also feel like burning, numbness, aching, and then again, finally pain relief. Most research does show that we need about 18 to 21 minutes of treatment to get maximum pain relief. And again, that's not typically what we see done in clinics. Immediate treatment for an injury is RICE, which I think everyone knows about at this point. RICE stands for rest, ice, compression, and elevation. So when I say rest, I don't mean sit on the couch and do absolutely nothing and just rest. I mean, stop doing that activity that aggravates the problem. So let's say running is something that aggravates the problem. Don't run. Maybe you can elliptical or walk or do some type of other workout. But when we talk about rest, we just mean limit the aggravating activity. Ice is going to, again, all those physiologic properties of ice: decrease cellular metabolism, reduce secondary injury, reduce pain, reduce swelling, just overall sort of slow down that acute inflammatory response. Compression, again, is going to decrease that pressure gradient between the blood vessels and tissues. So remember, we did that experiment where we held one hand up in the air and one hand down. Compression is also going to significantly increase venous return and increase the patient's ability to return some of those fluids that are building up in the area. Elevation is also going to assist with that, which is, again, that experiment we did where we held one hand up and one down and compared the color of our hand. So if we can elevate, we can also keep some of that fluid out of the area, which will reduce swelling in the long run. So again, there can be a risk of cold-related injury. We are most likely to see this in someone who has poor sensation or poor circulation. But the two things that we might see are, one, a cold-induced neuropathy. This is going to be most common, usually like the elbow or knee, where we have very superficial nerves, and then we apply an ice pack on top of that. So the common peroneal nerve, the ulnar nerve, those are both relatively superficial. And so if we put ice on those areas, the person may actually report some numbness, tingling, or pain along the distribution of that nerve. Typically, once the ice pack is removed and the tissue warms back up to temperature, those symptoms will start to go away. Frostbite, again, definitely something we want to avoid. It is seen with reusable ice packs because they do get relatively cold. Again, that large tissue temperature gradient. When you apply ice, the skin should become pink or red. If it shows pallor, which is blue or paleness, and cyanotic, which is blue, we want to discontinue treatment immediately. So it is important that we check on our patients throughout the treatment, that we give them like a signaling device or some way to get our attention if they start to get too cold during treatment. And that first time, I do usually do some periodic skin checks just to make sure the skin is looking like it's supposed to. Once they get through that first treatment, I don't bother them every single time by checking their skin throughout treatment, but I do want to make sure that they're tolerating treatment well. If I do have a patient that I know has impaired sensation or circulation, I will continue to do skin checks every time that they are on ice or heat. So if you are worried about any of these types of injuries, especially frostbite, you can use a different type of cold modality, one that doesn't have such a great tissue temperature gradient. You can decrease the duration of treatment, and again, observe those patients who have circulatory or sensory deficits. Contraindications and precautions. We're going to go over these for every modality, and when you guys do skill checks and comps, you're going to have to be aware of contraindications and precautions. So you're going to see these a lot. We're going to talk about them a lot. For cold, this is actually one of the shorter lists because, like I said, cold can typically be applied safely to most injuries and most people. A lot of these are actually precautions. So again, things we just need to be more cautious with our patient, not an absolute contraindication that no, they can't use ice. So cardiac or respiratory involvement, this is especially the case with things like the ice bath, which you guys will experience in lab, and you will hopefully understand why we need to take special care with our patients who have any type of cardiac or respiratory involvement. We're going to monitor blood pressure, heart rate, see what happens when we put someone in an ice bucket, and you'll see that there are some pretty significant changes. So we would want to avoid that particular modality with those particular patients. So we'll choose something else for them. Uncovered open wounds, simply cover it. It's more of a hygienic type thing. Circulatory insufficiency, again, we've talked about why that's so important, and we just really need to be cautious and observe those patients while they're using ice. If someone has cold allergies or hives, it is a real thing. They will pretty much tell you if you come at them with an ice pack. They will say, nope, can't do that. It makes me break out. I can't tolerate cold. So that's fine. We can use something else with them. If they have advanced diabetes, we're just primarily worried about sensation and having intact sensation. So we would want to be very careful with them. Peripheral vascular disease, same thing. That's more of a circulatory issue. Raynaud's phenomenon, that is where people get really cold hands and feet. Their hands and feet will turn like a bluish color, even when it's not that cold. And so they typically don't tolerate cold very well, as with lupus as well. So we'll typically stay away from cold with patients who have those known conditions. All right, so let's talk a little bit about heat. Heat is going to be indicated in the more subacute and chronic phases of recovery. Thermotherapy can be superficial or deep. So the ones that we're going to talk about primarily here are going to be our superficial heating agents. Those are going to be things like hot packs, paraffin, whirlpool. Those are all going to stay relatively superficial, which we're talking about, typically with less than 2 centimeters deep. Deep heat is going to go deeper than that, and those are going to be things like ultrasound and diathermy, which we're going to talk about separately a little bit later. With hot packs, paraffin, heat exchange is going to occur again through conduction. Those are going to be the most common ones, again, that you see clinically. So with heat application, we can control that inflammatory reaction and sort of speed along the healing process once we get to the subacute and chronic stages of recovery. It'll encourage tissue healing. It can help to reduce edema and ecchymosis, again, in the subacute and chronic stages. We're not going to put heat on someone who is in that acute inflammatory stage. Heat can help to improve range of motion before activity. And I do want to take just a second to sort of explain that a little bit. Just putting a hot pack on someone is not going to improve their range of motion. Putting a hot pack on someone is going to improve the elasticity of the collagen structures in that area. So if we put heat on someone and then we stretch them immediately afterwards, or we have them do some sort of exercise or activity that's going to induce a stretch or increase their range of motion, that's what's going to actually increase their range of motion. So it's the heat influences the extensibility of the tissue, so then we can stretch a little bit easier or get more range of motion when we're stretching. So again, just putting a hot pack on someone isn't going to improve their range of motion. Putting the hot pack on, then performing stretching activities is going to improve their range of motion, hopefully even more than not using a hot pack. That being said, it's also important that if you are going to be doing stretching activities with your patient and using heat, that you time it properly, that the patient gets the heat and then they do their stretch, not that they get the heat and then they go do something else and then they try to stretch later. If we're using the heat to try to improve range of motion, make sure they get the heat, they do the stretches, and then they can continue on with whatever else they need to do. The last one here, I would be a little cautious with promoting drainage from an infected site. I would typically stay away from heat over any area of infection. Heat, as we'll get into the physiologic properties, will cause vasodilation, which will allow drainage to occur. But if it's somewhere that's infected, I don't want to potentially spread that somewhere else. So while that's mentioned in the book, I would shy away from that one. So here are the physiologic effects of heat application. You may notice they are pretty much the exact opposite of the physiologic effects of cold application. So with heat, we're going to have vasodilation. Again, we're going to increase blood flow to the area. We're going to help to remove some of the fluids from the area. We're going to increase cellular metabolism. We're going to increase capillary permeability. And we're also going to increase venous and lymphatic drainage. So while we may be increasing some of the fluid buildup in the area temporarily, the idea is that we've also caused some vasodilation so that we can remove that fluid more easily as well. So that goes into edema formation and removal of metabolic waste. So yes, again, this is subacute, this is chronic. There may still be some edema lingering around. The idea is that while it may temporarily increase with the application of heat, it also increases the ability to remove it. So in the end, we should hopefully net less edema in the area. As I mentioned with the range of motion and stretching, heat will increase the elasticity of collagen-rich tissues, which muscles, tendons, ligaments, those are all very high, have high collagen content. It can cause decreased pain and sedation of nerves, decreased muscle tone and spasm, decreased pain, and it will increase nerve conduction velocity. So with heat application, the modality is actually going to lose heat as the body starts to absorb it. So again, as soon as you take that hot pack out of the hydrocollator, it's going to start to lose heat. So as quickly as you can, cover it up, put it on the patient, and then let it in the machine long enough to warm back up before you use it again. The maximum benefit is going to occur when the skin temperature rapidly increases. With hot packs, we do need to use insulators. And so you'll see when we practice with the hot packs, there are terry cloth covers that go with the hot packs. You just match up the shapes and put them together. The covers count as 2 layers, and then we use towels as further layers between the terry cloth cover and the patient. So part of that is hygienic reasons. We can then take the towels and throw them in the laundry, hang our terry cloth cover up to dry, and then we can use it again on another patient. Versus if we put the terry cloth cover directly on the patient, we would have to wash that in between each patient, and we typically don't have enough of those to do that throughout the day. Typically, when we apply heat modalities, we're going to use a minimum of 6 to 8 layers. If we're placing the hot pack on top of the patient, we're going to use 6 layers. If the patient's going to be laying on top of the hot pack and therefore compressing it, we need a minimum of 8 layers and possibly even more. Heat is going to be absorbed fastest in the first 5 to 6 minutes. If you are using hot packs that are in a hydrocollator, it is going to take a minute or 2 for the patient to really start to feel that heat. So just let them know that so that they can be expecting that. One thing that can happen when we apply heat is called rebound vasoconstriction. So again, we talked about heat is going to cause vasodilation. And then after the heat is removed, what can happen is that we can see vasoconstriction occur again. So as the skin starts to cool, or as the tissues start to cool back down to normal temperature, we can actually start to see some vasoconstriction happening. So again, if we have circulatory issues, we just want to be aware of that. What we do not want to see with heat application is called mottling. That is white areas with red splotches. When we put heat on an area, again, it should turn like a pink or red color. If you notice any white in the area, that is usually a sign that the tissue temperature is getting too high and we want to discontinue treatment at that point. So the effect on the injury response process as far as heat goes, heat is going to accelerate inflammation. So it's going to increase local cellular metabolism, which is going to increase the rate of healing in that area. Again, it can increase edema, but it increases the capability to remove it. And the ideal temperature for most heating modalities is somewhere in the ballpark of 104 to 113 degrees. You don't need to memorize that. Just know it's pretty warm. We can also use exercise as a form of heat. So when we say we have patients warm up on the bike, we literally mean we are trying to warm up their muscles by doing exercise. So active exercise or active contraction of muscles is also going to increase blood flow, increase cellular metabolism, increase intermuscular temperature. So we can actually heat a larger area than we could by using hot packs. I mean, think about somebody warming up on the bike, all the muscles that are involved in pedaling on the bike or walking on the treadmill. You're pretty much using every muscle in the lower extremity. Now think about how many hot packs you would have to put on that person to cover the same amount of area. It's just not practical. It's also more functional, right? If the person's walking on a treadmill or riding a bike, they're getting more benefit cardiovascularly, muscularly, functionally than just sitting in a chair or laying on a table and getting a hot pack. We can also get deeper into the muscles by doing exercise than we can by using different heating modalities. So there are some definite benefits of using exercise as a form of heat, but not everyone's going to be able to do that either. So if we can, great, let's use it. If not, let's use hot packs. So contraindications for heat. If they have an acute injury, they're in that acute inflammatory stage, we do not want to put heat on them at that point. If they have impaired circulation, poor thermal regulation, anesthetic, numb areas, decreased sensation in those areas, we've talked about that with cold. We just want to use more caution with them, make sure their skin's turning the appropriate color, they're not getting too hot, because that is actually where the majority of lawsuits occur in physical therapy, is from burns from hot packs. So we want to avoid that at all costs. So making sure that their skin is not getting too hot. I want to talk for a second about where it says advanced arthritis and vigorous heating. Again, this is more of a precaution. I do not want you to go into the clinic and say, well, my teacher said that we're not supposed to put heat on patients who have arthritis. That is not at all what I am saying. If you've ever worked with someone who has arthritis, they love heat. Heat makes them feel better, and they can absolutely have heat. If you think about it, arthritis is typically, by definition, it's an inflammatory condition, right? We're getting down to the bone on bone. Those bones are grinding against each other, and it's causing an irritation there. And so we just want to be careful, especially if we're using very vigorous heating methods, that we're not further irritating the situation. But like I said, most of our patients with arthritis are going to like heat. They're going to use heat on their own. And so they certainly can use heat. So again, just be cautious, especially if we're really, really, really heating the area, especially with deep heat, which we're really not getting into so much with like hot packs and paraffin and whirlpools. So you're pretty safe to use all of those. Neoplasms are a cancerous area, and so we don't want to put heat over any area where there is known cancer. Again, vasodilation, we're going to increase blood flow to the area. That's going to have to go somewhere, and so we don't want to potentially spread that anywhere else. Thrombophlebitis is a blood clot. So again, we don't want to vasodilate that area, allow that blood clot to now travel freely and then potentially travel somewhere really important like the lungs, the heart, or the brain. So if the patient has known blood clots, we are not going to really do much of anything with them, but we're certainly not going to put any heat on them either. So heat versus cold, again, pretty much complete opposites. So again, heat is going to cause vasodilation. Cool blood is going to come into the area, transport the warmer blood away. So the heat is going to spread a little bit. It can reduce pain. Cold typically penetrates a little bit deeper than heat and lasts a little bit longer because we do have that sort of decrease in sensation to the local area. Cold will also reduce pain, and again, as I mentioned, it is a little bit better for muscle spasms. So how to decide when it's safe to switch from cold to heat. Evaluate the patient, determine is the area still warm to the touch? If it is, we need to continue with ice. Is it still sensitive to light to moderate touch? If so, continue with ice. Does the amount of swelling continue to increase over time? If yes, stick with ice. Does swelling increase during activity? Does it limit the joint's range of motion? Would you consider the acute inflammatory process to be active? And do they continue to improve with use of cold? So again, if you answer yes to most of those questions, stick with cold. If you can answer no to most of them, then it might be safe to switch to heat at that point. All right, so that is your introduction to thermal modalities. We will go over the clinical application of thermal modalities. We'll do that lecture in lab, and then we'll go through all the different modalities and actually have a chance to practice them. So I will see you in lab.